Good morning and welcome. Thank you, Davina. As Davina said, I'm David Messenger, Managing Director and Founder of the Elder Homes Group. Davina slightly got the numbers wrong because we've actually, over the last few months, progressed with our acquisitions. We are now up to 19 homes, employing over 1,000 staff and caring for over 1,000 service users. We all here today know of the crisis in the care industry, the problems around funding that have all been well publicised. I've been asked to present a little on the future of residential care. So a little later on, I'll give you my views of how possibly the residential care market could move forward, which clearly will contradict the currently well-held view that domiciliary care is the only solution. Therefore, I want to share with you our experiences at the Elder Homes Group. I've called my presentation the 5 senses because I believe that it's these senses that have helped me along the track that I've taken to date, and also helped me make many of the decisions and possibly hopefully the right decisions that I have to date. and also the reason for me doing what I do today. As you all know here today, our senses give us great comfort, memories, enjoyment, tears, and laughter, particularly important in person-centered care. I would like to share with you, through my eyes, my experiences, my views, and hopefully help us build bridges, new relationships, better systems, and most importantly, a better quality of care for our clients within our care. Let me take you back to even prior to me leaving school. My father at that time was a dairy farmer. I, at the age of 13, 14, took responsibility of caring for over 100 baby calves, the calves born to the dairy herd. This was prior to going to school in the morning. I used to provide food, a warm bed for them, water, a warm bed for them to sleep in, care and affection, and also, most importantly, that medical attention when it was required. Me, I left school at the age of 16 with no qualifications. However, the following year, I decided to enroll in Oakridge Agricultural College because of my farming background, where I am pleased to say, after some 3 fun years in Edinburgh, I obtained an OND in agriculture and an HND in business. And I believe that it is those that have set on my path to where I've got to today. And it just shows when you have an interest in something, you can achieve. At the same time, I also started a small dairy herd. That grew in size over the 4 or 5 years period. And it accumulated a value of a staggering 1.2 million in 5 years. I thought, fairly impressive. Well done. After flunking out of school, I'd done okay. After a drunken afternoon out with my solicitor and accountants to celebrate that first milestone, that first million, I suppose, they mentioned to me that there was a hotel they knew of with planning permission that had planning permission to become a care home. So, after sleeping on it that night, I suggested to my solicitor that we view it, make an offer. Following that viewing, I thought, yeah, I am the man for the job. I thought, I can do this. However, there was more to it than met the eye. After the builder going bust, 3 months into the project, me actually having to buy back the contract, run the build contract, because we couldn't afford to sell it on to anyone else. 2 years on, I proudly opened the doors to my first care home. 60 beds, but sadly no en-suites. The registration officer, viewing the home, said, "David, absolutely fantastic, first class. Why have you no en-suites? The only thing that is missing is en-suites." I said, "Well, perhaps if your predecessor had as much vision as you, they would have had. Here are the plans." So even that long ago, en-suites were the thing to have, as we know today. During that time, there was a young lady referred to our home. At that time, it was only registered for the elderly. This young lady was 25, lived in the area. However, her family could not cope with her at home. She'd been told that she would never walk again. However, after some 6 months of intensive care and physiotherapy from my then staff, she could stand unaided. Some 12 months on, she could walk with the aid of sticks. The family was so pleased, I cannot tell you. It brings the tears to my eyes today, some 20 years on. Within the next 10 years, I opened a further 4 homes. In the next 5 years, a further 10, now totaling 19 across the UK. Throughout these years, I've seen considerable changes. However, one of the most concerning changes to me at this time is the service users that have been referred to us, that have been attempted to be cared for at home, that are coming in with much higher needs, in very bedraggled state. And sadly, in my opinion, possibly many of these placements should have been considered much earlier. I feel, my feeling, is that the care for these people have perhaps been compromised in some way, no matter of their age. So, is domiciliary care the right thing for us to support? Yes, some of it's good, but recently I was at a sportsman's dinner. I sat with 2 care home providers that also ran domiciliary care units, domiciliary care. And after a couple of glasses of wine, my question to them, on a little bit of an investigative thing for today, was I've never entered into domiciliary care because I could never see how it could be policed. And my concern is how do you find it being policed? One says, to be honest, it makes me sick. The other, she says, I couldn't sleep at night. I had to hand the business over to my son to operate it. So if that is the owners of domiciliary care, I think possibly questionable. We all seen Winterbourne View, what happened there within a care environment where there was other people present. What could be happening to our loved ones, your father, your mother, that is being attended to by one carer? This leads me on to a few facts that I've put together for you on my PowerPoint. And I think if we don't act now, we might find ourselves as a whole fighting for our loved ones to be cared for in this country. Our graph here is based on my experiences within elder homes. what has happened throughout the years, as from 1995. Clearly we have acquired additional homes and things, but the trend is there. The trend is there. We obviously had some supported living throughout the early years, some dementia, some nursing residential. Clearly that grew with the acquisition of bed numbers, etc. But if we go to 2008 up to 2009, this is where you see the higher level of more challenging mental health clients that are actually coming through to us, the dementia people that we're actually having to care for. Our units are slightly larger, so we managed to have 70, 80 beds to try and keep the cost of the care down to a level that is sustainable. Rather than a small home where there'll be massive cost, £3,000, £4,000 a bed, that the NHS, CCG, etc., could not afford. Here, we pretty much ours mirrors what was on the previous slide across the UK. Obviously the 65 plus age group, the growing UK projected by 40% over the next 20 years. The dementia, it is estimated that by 2021 there will be 1 million with dementia in the UK. This is expected to rise to over 1.7 million people by 2051. Quite astounding. Here we are clearly gives a bit more in-depth as to the rise in the demand for the elderly population from 2011 to 2026, and likewise in the specialised care. And as we all know here today, I just had coffee with one of the directors from the CCG this morning, and clearly he was exactly on this, the drop in funding and the increase in demand, and how do we manage to achieve what we are attempting to do, to provide quality care to all those in the UK that need it. Possibly some facts that you don't know. We mentioned this to Davina earlier, and even being a publicist, she wasn't aware of this. I hope you don't mind me saying that, Davina. But actually in Germany, because of the sky-high cost of care, etc., the country's elderly and sick are being sent abroad to Asia, to Hungary, other parts of Europe, Czechoslovakia, etc. Here again, in Germany, over 7,146 Germans living in care homes in Eastern Europe because they cannot afford the cost. More than 400,000 citizens currently unable to afford German care home fees, 5% per year. Germans unable to afford the growing cost of aspiration and shrinking population. Again, clearly demonstrates the issues that are in Germany, the rise in care home costs, stagnant pensions, and longer life expectancy. Exactly the conversation I had with the gentleman from the CCG this morning. That takes us on back to Britain. What can we do in Britain to ensure that does not happen here? Obviously, in the words of Winston Churchill, victory, victory at all cost. And I think that's what we need to do. We all need to be working together to provide a better future, better care for our elderly, the vulnerable, etc. I feel sure that our cause will not be suffered to fall among men. Takes me on to my sight, my vision, my feelings. As I said earlier, is domiciliary care the right thing, the right way to go? I would suggest within some of our residential establishments that we have some unregistered beds so that they are provided at a set cost. We already have one unit in the group that actually does that and works very well. We managed to provide that care cost for the food, etc., at around £250 to £300 per week, rather than £600 to £800 for care. So the cost of provision would be lower, and if they were utilised similar to extra care beds, we could obviously, as we do, we have an outside carer coming in, or we have a carer on site to do that care, rather than travelling the length and breadth of Manchester to care for 3 or 4 people and maybe them receiving 15 minutes of care. We move on to how can the care costs can be reduced in the future. I think very similar to what actually happens in the domiciliary care, that there is a bespoke, personalised care plan, because all the clients do not need the statutory and stipulated care that is placed on us by CQC. I'm not saying to reduce the quality of care, not at all. But I am saying if we have an unregistered bed, Mrs. Jones needs 1 hour of care, she can be provided with 1 hour of care. The staffing level could obviously be monitored accordingly. So create bespoke, personalised care plans. We do that with many of our higher level clients. I'm saying do it with the lower clients as well. Create a personalised care package reflecting the individual's needs, thus reducing the stipulated minimum staffing levels, as I said, in the care homes placed on us by CQC, where we should be. I've got a slide shortly which is quite staggering as to the cost. The care costs reduced by half compared with that of domiciliary care. Domiciliary care is charged out between £15 to £20 per hour. A carer within any of our establishments, depending on qualifications, will receive between £7 and £10 an hour. So a staggering saving immediately, let alone the travel time, etc. The visions for the future. Partnership and funding between the state and individuals, encouraging growth of the privately funded market, protecting the assets against the cost of care. Clearly, a lot of people have, with massive assets, have a financial advisor. Why should somebody that's living in their own house, possibly £150,000, not have that same advice, how to protect their assets? My words: voluntary insurance, capping the social care bill, individuals' property could be sold, as we know, care fee insurance policy acquired, possibly a new one, which I think may work, to help the client retain their assets, rental property, management system, by a housing association or whatever, someone that is coming into the home, the property is placed with them, the income from the rental assists in paying the care fees. We already have the care allowance, etc. Could be a little short, but at least they would maintain some of their assets. With regards to public funding, how can this be best used to support the care needs? By providing a single environment for the delivery of care, rather than carers travelling for miles. Providing better policing. As I said, how do we know what someone does in one person's home? My words: it will provide better controlled quality of care, environment, comfort, security, and more time spent delivering the care rather than reducing the costs and travelling. Saving money on customised adaptation of housing, travel time, as well, and more than anything else, being environmental friendly. Joint commissioning between the NHS, CCG, local authority, building essential relationships with effective communication, providing consistency in the delivery of the service, so that a more bespoke care package is commissioned, thus reducing the cost, enabling a better service to be delivered to our clients. This takes me on to a chart which my in-house finance director has put together for me. And clearly, as it shows here, the accommodation cost, the food cost, domestic laundry. However, this massive area here is the stipulated care cost that is asked for us to be put against each client that is placed in our residential home. So hence, increasing the cost to $489 per week. Similar with nursing. Obviously nursing is slightly different, but clearly there needs to be nursing. But I'm talking about lower end of care, the clients that are referred to us. This takes me on to a lot of the new innovative things that's out there in the market. Some of them have been used to date. These things clearly, hopefully in the future, will help reduce cost. There's obviously the computerized pill boxes and things that's already used in domiciliary care. Clearly these could be used in the care home environment for lower categories of care. Sorry, lost my place. So that takes me on to possibly the conclusion. As I said, there's a lot of technology out there. So I hope I've raised some interesting questions and some possible answers. Maybe not all right, but at least I've tried. And before taking any questions, I'd just like to say thank you all for attending it, in case I'm short on time. And thank you very much to my lovely wife, Alison, that has assisted me in putting together this presentation. Because behind every successful man, whether it be Tony Blair or Barack Obama, there's always a strong woman wanting to get out. So my Alison was handing out the things this morning. So thank you for listening, and let's have any questions, and hopefully I can try and find some answers.
I own a care home in Wiltshire.
Yes.
We're finding the local authority, and now when they are actually putting people to us, the dependency level is not only high, but their mental health issues really are outside the scope of dementia, so are actually people that should be really under the Mental Health Act. How do you find you obtain extra funding for people who have serious mental health issues as well as dementia?
Obviously, I again had this discussion with the CCG director this morning. Many of our homes are actually larger, and within our units, we have a cross spectrum of different categories of care. We have a 72-bedder in Nottingham, and we have 20 beds of residential, 20 nursing. We have a mental health unit and a 10-bedded higher end spectrum of care, and that's how we manage that care within that, and it manages to keep the cost down for the referring bodies. If someone improves, they can go up and down through the units, and that's how we tend to manage it, and it works well. The unit is 100% occupied, has been for the last 4 years since it opened.
So you do get more money, obviously, for the ones with mental...
Pardon, could you...
With people with mental health issues, maybe over 65,
yes,
you still receive more money than the going standard rate.
Clearly, we need to do, as I said earlier, there needs to be a bespoke care package put together for them, the additional hours demonstrated, and so on and so forth, as to the care that they require. And clearly, within those units, we have registered mental nurses, higher trained staff, etc. And to help maintain those clients at a level. And I must say that some of those clients actually drop back down to possibly a nursing unit or residential unit as they've improved, they've settled into the regime, etc. Okay, I think that's it all. So thank you very much. Thank you for coming. Excellent. Thank you for listening.